Hello, and welcome to Clinical Care Options Oncology Podcast. I'm your host, Marie Becker. Today's episode features Dr. Lauren Byers from MD Anderson Cancer Center and Dr. Christine Hann from Johns Hopkins University. They will be discussing novel therapeutic agents targeting B7-H3 in small cell lung cancer with a focus on antibody-drug conjugates. This episode is part of a larger educational program titled Clinical Focused in Small Cell Lung Cancer, Emerging Insights on B7-H3 Targeted ADCs and Their Transformative Potential in Clinical Practice. For more information on our presenters, along with a link to the full educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, I'm Dr. Lauren Byers. I'm a thoracic medical oncologist at MD Anderson Cancer Center in Houston, Texas. And I'm really pleased to be joined today also by Dr. Christine Hann.
Hi, I'm Dr. Christine Hann. I'm a thoracic medical oncologist at Johns Hopkins University in Baltimore, Maryland. Happy to be here.
Thank you. Well, I think it's really exciting to be here together today, in particular, because we know that small cell lung cancer has historically been a really challenging cancer for us to treat. So for many decades, there was very little progress for what we could offer our patients and what we were seeing in terms of the benefit of common therapies. And now I think we're really, a special time in the development of new drugs and newer ways to take care of patients with small cell lung cancer. So, a couple of questions that, commonly come up is, sort of how common is small cell lung cancer? And, about 15% of all lung cancers that are diagnosed, at least in the United States, are small cell lung cancer. And, as I was mentioning before, these often are extremely aggressive cancers. And even with, current standard treatments, it is not uncommon for patients, unfortunately, to have recurrence quite early. So that's been a real challenge. Limited stage small cell lung cancer, which is lung cancer that is being treated with curative intent and is confined just to one side of the chest and in an area that can be treated definitively with radiation. In the past, most of our tools were chemotherapy or radiation. More recently, we have immunotherapy that is now a standard of care for limited stage disease based on the I-DXd phase 3 trial. And with extensive stage patients, these are the patients that have more advanced disease, typically metastatic, and are treated as the current standard of care based on the phase 3 Caspian and Empower 133 trials with a combination of platinum, etoposide, and anti-PD-L1 therapy. So even though we've had, some advances, especially with the addition of immunotherapy, those advances really to date have been somewhat modest. The improvement with adding anti-PD-L1 therapy, for example, extended overall survival. But if you looked at all comers population of those who had extensive stage small cell lung cancer, the benefit was only in the range of improvement in overall survival of around 2 months. And so again, really, really modest. For the limited stage patients, we did see a more significant benefit with the addition of anti-PD-L1 therapy, with the I-DXd trial showing that adding that durvalumab treatment actually on average extended survival by 2 years. So that was quite a jump in terms of the survival for those patients, but we still have a long way to go in terms of having more treatment options for our patients. So today we're going to be talking about new approaches targeting B7-H3, especially in antibody-drug conjugates or ADCs. And just before we get into the trials with Dr. Hann, I'd like to talk for just a minute or two about, why B7-H3 is a really exciting target. And so one thing, we're always looking for when we're thinking about new therapeutics is, how frequently is a target expressed within these cancers. And the majority of small cell lung cancers do express B7-H3. It is also expressed in several other cancer types, and so it's being developed as a target for many cancers beyond just lung cancer. And the expression of B7-H3 is also associated with a poor prognosis and may have a a role in suppressing the immune response or immune regulation within tumors. So there probably are several ways, why this may be a good target to think about for small cell lung cancer. So, one of the things that we were going to talk a little bit about to begin with is, what are ADCs or antibody-drug conjugates? And so I describe these to my patients, sometimes as a targeted chemotherapy or as sort of a smart bomb. So it has one part of the drug that is an antibody and will bind to that B7-H3 on the surface of cancer cells. And bringing with it are the payloads, and those are the cytotoxic payloads that will then cause, damage and ultimately kill the cancer cells where those drugs are delivered to. So Dr. Hann, you've been, involved and very knowledgeable in terms of, some of the clinical trials that are going on with this target for patients with small cell lung cancer.
Thank you, Dr. Byers. That was a great introduction, and I'm really excited to be joining you on this topic. I think this class of drugs has led to a lot of excitement, and we've seen results from at least 4 different types of B7-H3 antibody-drug conjugates over the past couple of years at various meetings. And I'd like to highlight some of the studies that we've heard about at these international meetings. First, as you described, these are all molecules that have 3 parts: an antibody, which helps direct the molecule to cancer cells that express, or any cells that express B7-H3, the payload, which is usually chemotherapy, often a DNA topoisomerase 1 inhibitor, and a linker that binds the drug to the antibody. And ideally, this linker is very secure, so there isn't leakage of the drug to off-target sites. The most mature data that we have for B7-H3 ADCs in small cell is from ifinatamab deruxtecan, or I-DXd. This molecule delivers deruxtecan, a DNA topoisomerase 1 agent, to cells that express B7-H3, and was first studied in a phase 1 study called IDeate-Pan-Tumor01. This study was comprised of 2 parts. The first part was a fairly standard dose escalation to identify a dose with acceptable side effects that has some preliminary evidence of tumor activity. And the primary endpoints of part 1 were to really look at adverse events, serious adverse events, and dose-limiting toxicities. The study also contained part 2, which then took a recommended phase 2 dose of this agent and looked at specific cohorts of patients. Overall, 22 patients with relapsed small cell were enrolled in the study, and we saw an objective response rate of 52.4%. This is a high number for patients with pretreated small cell lung cancer. The most common side effects were GI. Nausea was one of the most common. Fatigue was also seen, and hematologic toxicities, most notably anemia. For the small cell cohort of patients, a typical patient had received 2 prior lines of therapy, so we are talking about a heavily pretreated patient population. These promising results from IDeate-Pan-Tumor01 led to I-DXd-Lung01. This was a study specifically designed to evaluate activity of I-DXd in patients with relapsed small cell lung cancer. Eligible patients for this trial had to have received at least 1 prior line of therapy. This was a platinum-based first-line therapy, and up to 3 prior lines of therapy. They also had to have a pretty good performance status, ECOG PS of 0 to 1. And interestingly and importantly, patients with asymptomatic brain metastases, treated or untreated, were allowed on this trial. IDeate-Lung01 was comprised of 2 parts as well. A first part, which included dose optimization, taking 2 of the most promising doses from IDeate-Pan-Tumor01 and randomizing patients to receive one of those 2 doses, either 8 milligram per kilogram every 3 weeks or 12 milligram per kilogram once every 3 weeks. There was also a second part, which included extended enrollment of the final selected dose. In total, 88 patients were enrolled in the dose optimization portion, and those results have been reported. The primary endpoint of the dose optimization was objective response rate, and exploratory endpoint was intracranial response. Overall, the objective response rate was 26.1% for the patients who received the lower dose, 8 milligram per kilogram once every 3 weeks, and 54.8% in the higher dose, 12 milligram per kilogram every 3 weeks. Side effects were similar between the dose groups, though tended to be higher grade and a little more frequent in the patients enrolled at the higher dose level. But given the high efficacy and tolerable side effects, the 12 milligram per kilogram dose was taken to the second part of this study, and we are awaiting those results in an upcoming Congress. To talk specifically about some of the toxicities, they were mainly GI and hematologic. Nausea and decreased appetite were the most common and were often low grade, even at the higher dose level. Cytopenias, including anemia and neutropenia, were seen and were higher and could be grade 3 or more. A toxicity of special interest for many antibody-drug conjugates, including I-DXd, is pneumonitis. And importantly, any grade pneumonitis was observed in 9 out of 88 patients in part 1 of this study, and something that we need to watch out for in the future. Talking specifically about CNS responses, 42% of patients enrolled in the study had brain metastases at baseline, and responses were seen in 37% of these patients. So taken together, an objective response rate of 54.8% at a 12 milligram dose, as well as 37% of intracranial responses, are really promising numbers for patients with relapsed small cell and encouraging for future study. At this point, I should mention that there are ongoing studies looking at I-DXd. There is the I-DeateLung02 study, which is a phase 3 multicenter randomized open label study of I-DXd versus treatment of physician's choice, so standard chemotherapy for patients with relapsed small cell who have received only one prior line of platinum-based therapy. And this study is ongoing, really asking the question of second line results on a larger scale for this drug. And another study that is looking at I-DXd in the first line setting has recently been opened. This is a 2-part study where cohort 1 receives I-DXd in combination with atezolizumab maintenance after patients have already completed induction chemoimmunotherapy as standard of care. And cohort 2 asks a very intriguing question, which is whether I-DXd might be used in place of one of the components of first-line chemotherapy. So in this study, I-DXd is combined with a platinum agent and atezolizumab as part of induction in the first-line setting. I'd like to take a moment and talk about a few other antibody-drug conjugates that have been studied in earlier phases, and they're in earlier phase evaluation, one of which has been recently reported and published. YL201 is a novel antibody-drug conjugate targeting B7-H3, and results from its phase 1 study have been recently published. In this dose escalation expansion study, 79 patients with relapsed small cell were enrolled. Most had one prior line of therapy, so a slightly different population than we saw with the I-DXd study. And 33% had brain metastases. The objective response rate in this study was 63.9%, and responses were seen in most of the dosing cohorts of the dose escalation portion of the study. In terms of most common toxicities, nausea and fatigue were seen in 25 to 30% of patients. Grade 3 cytopenias in 25 to 30% of patients. And notably, ILD and pneumonitis were rare events occurring in less than 2% of all patients enrolled on the study. And they also looked at intracranial responses. 3 of 10 patients with small cell lung cancer had intracranial responses to therapy as well. HS-20093, another antibody-drug conjugate, whose results have been, phase 1 results have been reported. In the US, this is also known as GSK277. In the phase 1 dose escalation expansion study, the results of the small cell cohort were presented last year at the World Lung Conference. And 56 patients with relapsed small cell were enrolled at 2 doses. At the lower dose, the objective response rate was 61.3%. At the higher dose, 50%. The most common AEs were hematologic and GI, and hematologic were often grade 3 or higher. And one final B7-H3 ADC is MHB088C. This antibody-drug conjugate is notable for having or carrying a super topoisomerase 1 inhibitor, which is reportedly 5 to 10 times more potent than DXd, with a shorter half-life. This agent is being evaluated in a phase 1, phase 2 study, and early data of 31 patients with relapsed small cell reported a objective response rate of 61.3%. In terms of toxicity, grade 3 and greater toxicities were primarily hematologic. So that is a brief summary of some of the early phase data from the ongoing studies of B7-H3 ADCs in small cell lung cancer.
Thank you, Dr. Hann. I think it's really encouraging to see that level of response rates in these patients, especially those who've had previous treatment. This is very different than what we've seen in the past with traditional chemotherapy agents, where usually the response rates were much lower and often not nearly as durable as what's being seen in these trials. One of the things that you mentioned also that I think is also really exciting, thinking about kind of how we may move forward in terms of future directions, is this idea also that these antibody-drug conjugates could ultimately replace our traditional chemotherapy approaches. And I think that that's something that, as you mentioned, we're starting to see already being explored within the context of some of the new clinical trials, as well as thinking about how some of the other new types of drugs, including T-cell engagers, could potentially be used in combinations with antibody-drug conjugates as a way to enhance both the immune response as well as the cancer cell killing. One thing that Dr. Hann also touched on in terms of the side effects included, some of the side effects that are important to keep in mind if you're treating patients with antibody-drug conjugates, and including, being very, aware of the potential for ILD, for interstitial lung disease. And so looking for patients who may develop new cough, shortness of breath, hypoxia. Those are things that, would be red flags in order to really, pay attention to. But largely the data so far has suggested that these drugs are overall well tolerated and with, I think, reassuring safety profiles. The other thing that I think is somewhat unique for this target compared to other ADC targets is that it's very, frequently expressed in these cancers. And so I think that also is a real advantage in terms of, it looks like this potentially could have benefit very broadly across patients with small cell lung cancer, as well as other cancers, as I mentioned, early on.
I agree with that. I think I'm also excited to see the different ways that B7-H3 is being used as a target. So there have been reports of CAR Ts being developed against it, as well as different types of payloads. So a targeted antibody then carries a targeted drug. So BCL-XL has also been used as a payload in a B7-H3 antibody-drug conjugate. So it feels like the possibilities are pretty wide or endless in terms of how to use this target.
So it's been a pleasure to be here today with all of you, and we're looking forward to our upcoming text module that will provide more details on the latest data and includes a downloadable slide set.
Thank you, Dr. Byers and Dr. Hann, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Clinical Focus in Small Cell Lung Cancer, Emerging Insights on B7-H3 Targeted ADCs and their transformative potential in clinical practice, please click on the link in the show notes. Be sure to come back soon for an in-depth look at these new therapies in an upcoming text module with downloadable slides and an expert commentary. As always, thanks for listening.